Hi, today's lecture will be on surgical management of odontogenic tumors. Um, as you all know, odontogenic tumors means tumors that arise from the apparatus which forms the teeth. And most of the time, these jaw tumors are required to be managed surgically under general anesthesia. So definitely it comes under the purview of the oral and maxillofacial surgeon. So, but still, as a BDS graduate, you are expected to know about odontogenic tumors. You should be able to identify it. You should know the kind of investigations required for the management of these tumors, and also, of course, about the various surgical procedures that are required, and refer the patient to a oral and maxillofacial surgeon. So at the end of this topic, you are expected to know about the principles of the surgical management relating to both enucleation and marsupialization. We should be able to outline the treatment options according to the probable diagnosis, anatomical relationship, size of the lesion, and we should be able to identify the level of the operator experience required for surgery and recognize cases that require referral. And of course, you can participate in the patient counseling either alone or in conjunction with the specialist. So, as you all know, tumors are neoplasms or new growths of abnormal tissue in the body. It can be either benign and malignant, and I am sure you are very much aware of the various clinical and characteristic features of benign and malignant tumors. Benign tumors are slow growing, they are encapsulated, and they will have a bit of peripheral expansion, and they push away the adjoining structures. You won't see any metastasis if it is a benign tumor, and well, sometimes they can be locally aggressive. Whereas malignant tumors, they rapidly infiltrate the surrounding tissues, including the vital structures. It can endanger the life of its host. It can prove fatal. And it exhibits metastasis in the distant parts of the body, usually through lymph and bloodstream. And the jaw tumors can be classified as odontogenic and non-odontogenic tumors. So, what are odontogenic tumors? They are a group of lesions arising from the tooth-producing apparatus or its remnants, and it may originate from epithelial and or ectomesenchymal odontogenic tissues. What are the principles of management? So, first and foremost is the history. You should know about the duration of the growth, when it started and how long it has been there, and the mode of onset and progress, the site and shape, the change in character of the lesion, and of course the associated symptoms like pain, paresthesia, anesthesia, nasal obstruction, tenderness, trismus, lymphadenopathy, etc., loss of body weight, and recurrence. How do you clinically examine a tumor? First is the inspection, where you just look at the tumor, you just observe the tumor. First, find out whether it is whether it is single or multiple, the site where it is present, the anatomical location, the shape and size of the lesion, the color of the lesion, and the surface, how it appears, whether it is smooth, lobulated, ulcerated, or if it is a fungating growth, whether it is pedunculated or sessile, and the skin over the swelling. That is, you have to check the temperature. So on palpation, you check for the consistency of the lesion. A lesion can be a soft lesion like a lipoma. It can be hard or indurated firm like fibroma, or it can be bony hard like osteoma. And check for fluctuation and eggshell crackling if there is a cortical plate expansion, and the consistency whether it is uniform or differing at various locations, and check if there is any presence of pulsation. This is called as thrill or bruit, which represents a vascular involvement. And check if the tumor is fixed or mobile. And of course, you need to check the lymph nodes too. In case of a malignant tumor, you can expect to see a lymph node metastasis. Coming to the imaging techniques for odontogenic tumors, you have various radiographs depending upon the location. You can either go for an orthopanomogram or a lateral view or a paranasal sinus view, etc. And you have also CT with 3D reconstruction, MRI, magnetic resonance images for imaging for soft tissue extensions and lymphadenopathy, For lymphadenopathy, USG ultrasonogram will be the ideal imaging method, and you can also go for angiographic studies if you are suspecting a vascular tumor. Okay, that is a OPG, a radiograph showing a tumor. You can see there is a kind of radiolucency in the body of the mandible, and you can see it is kind of amorphous. It doesn't have a definite outline like a cyst. A cyst will appear like a smooth radiolucency with a mild radio-opaque outline. But here you can see that you cannot make out the outline. It is quite haphazard, and you can also see an impacted tooth associated with the lesion. So this is a characteristic appearance of a tumor, and that is a computed tomography scan, CT scan showing a tumor. You can see the radiolucent expansion of the bone, and that is an MRI depicting a tumor. Coming next, after the radiographic investigation, you know that there is a lesion there. Then you go in for the biopsy, for the histopathological studies. You have various types of histopathological studies, like you can go in for an exfoliative cytology, aspiration biopsy, FNAC, that is fine needle aspiration cytology, and excisional or incisional biopsy. If it is a small lesion, you can straight away go for an excisional biopsy where you excise the entire lesion and you send it for histopathological analysis. If it is a large lesion, you just take a piece of the tumor, check what kind of tumor it is histopathologically, and you can formulate the surgical management accordingly. What are the principles for surgical management? The first and foremost is complete eradication of the lesion. You are not supposed to leave out any residual tumor tissues. And then you have to preserve the normal tissue as much as possible. Preservation of normal tissue as permissible. So when you think about complete eradication, you should also think about management of the vital tissues and the preservation of the normal tissue as much as possible. And the excision should be with least morbidity. Restoration of the tissue, loss, form and function. After the excision there is going to be a defect, so reconstruction has to be done. That's what we now call as restoration of tissue loss, form and function. And in case the tumor is something which is very much prone for recurrence, you need to go in for a long-term follow-up where you check the patient periodically for recurrence. So Gold, Upton and Marks in 1991 came up with a classification or the various methods for surgical management of tumors. So you have enucleation, which is just same like a cyst enucleation, where you remove the entire lesion, and then you have something called as curettage, where you just scrub and remove the tissue tumor, and we have marsupialization, recontouring, resection with or without continuity defect, and disarticulation. So now we come to enucleation with or without curettage. It is mainly used for excision of cystic lesions. So small non-aggressive benign tumors that tend to grow by expansion rather than infiltration of the surrounding tissues will require an enucleation with or without curettage. And there should be a distinct separation, a cortical margin between the lesion and the surrounding bone, so that you can plan your treatment and carry it out effectively. The lesions that normally go in for this enucleation with or without curettage are ameloblastic fibroma, ossifying fibroma, cherubism, hemangioma, eosinophilic granuloma, central giant cell granuloma. Now we come to the most important part of tumor management, which is resection. Resection means you cut and remove a part of the bone along with the tumor. So this can be either with or without continuity defect. So what do you mean by without continuity defect? This is the kind of management which is required for benign lesions with propensity for recurrence. So it is also called as en bloc resection, marginal mandibulectomy or marginal resection, where the inferior border of the mandible is spared. I'll show you some pictures in the forthcoming slides so you'll be able to understand better. And resection with continuity defect is for extensive lesion where the inferior border of the mandible is also included. There is another name for this which is called as segmental resection. So this is en bloc resection or marginal mandibulectomy. The excision is carried out but the inferior border of the mandible is preserved. So the integrity of the mandible is maintained. So that is a surgical picture for resection with without continuity defect. We can see the first picture where the inferior border of the mandible is preserved. The second picture, that is a segmental resection. This is called as resection with continuity defect. So that is a excised specimen after segmentary resection. Then you have another one concept known as hemimandibulectomy, where half of the mandible is excised and removed. So resection of the mandible from the midline involving the body and ramus of one side. If the condyle is also removed along with the resected section, it is called as disarticulation. So we can have hemimandibulectomy with or without disarticulation. So this is hemimandibulectomy. You can see half of the mandible from the midline involving the body and the ramus is completely removed. So that is hemimandibulectomy without disarticulation. You can see a segment of the ramus still remaining. So that retains the condyle in its fossa. And the next picture, it is total hemimandibulectomy with disarticulation, where half of the mandible along with the condylar process and coronoid process is removed. So that is a resected section after hemimandibulectomy. So now we come to the maxillectomy. When there is a tumor involving the maxilla, you go in for maxillectomy. The access to maxilla is obtained by an incision which is called as Weber-Ferguson incision. So the tumors confined to the posterior aspect of the maxillary sinus can be managed with a conservative resection that spares the premaxilla. That is, when the tumor is involving only the posterior aspect, the anterior aspect of the maxilla, which is also known as premaxilla, will be preserved. And when the tumor is extending up to the roof of the maxillary sinus but does not invade, the orbital floor should also be included in the resection. If the tumor is crossing the roof of the maxillary sinus involving the orbit ethmoid sinus, we do a procedure called as orbital exentration, where the contents of the orbit is also removed. So these are the various methods or various types of maxillectomy, and you can see the excision is done according to the involvement of the tumor. So the more extensive the tumor is, the more the maxillectomy is going to be more aggressive. It is that's a picture of a dentigerous cyst involving an impacted canine. You can see that an enucleation has been done. So there is a maxillectomy, a surgical picture of a maxillectomy done, and that is a post-operative picture where you can see a defect in the palate. Normally, you need to go for a reconstruction. Initially, they'll give an obturator or a palatal splint to cover the defect. This is a picture of a patient who has undergone orbital exentration. You can see the entire part of maxilla as well as the orbital contents has been excised and removed. And as a part of reconstruction, the patient has been given a prosthesis, which you can see in the first picture. That is a resected segment of the maxilla. And this is a picture where a very extensive tumor has been surgically managed by a maxillectomy involving the orbit and the orbital contents. Okay, now as you all know that after a surgical procedure you have removed the tumor as well as the surrounding bone, maybe sometimes the soft tissues too. So you need to reconstruct it. You have to cover up the defect. So how do we do it? Why do you want to do a reconstruction? First is for restoration of movements and equilibrium of the mandible. For example, if you have done a hemimandibulectomy, there is going to be a huge defect which is going to affect the quality of life of the patient. So you have to restore the movement and the equilibrium of the mandible by reconstruction, so that the patient will be able to speak, and it will also help him in his speech. For maintenance of normal occlusal plane, floor of the mouth and the tongue's anatomical position, because during this excision the muscles like genioglossus and genioid, all these muscles will be excised, which can affect the movement of the tongue. So in order to maintain the tongue in its proper anatomical position and also to maintain the normal occlusal plane and the floor of the mouth, reconstruction is mandatory. And for restoration of near normal feeding, so especially after a maxillectomy, there is going to be a huge defect. So this is going to affect the feeding of the patient. So that defect has to be reconstructed or covered up so that the patient will be able to continue with this normal feeding. And for acceptable aesthetics and function, that is understood, and for social acceptance. So you have two types of reconstruction. One is known as the immediate reconstruction, the other one is late reconstruction. Immediate reconstruction is the reconstruction which is done with the primary surgery. So it is a single stage surgery, early return to function and minimal compromise of aesthetics. Patient immediately after the surgery, the reconstruction is also done, so the patient is can lead a proper life, or he can manage with his normal mandibular or maxillary functions immediately after the surgery. So normally for immediate reconstruction, you either use a reconstruction plate or a defect bridging plate, or some can also use bone grafts where iliac crest, costochondral graft or fibula is used. And what are the disadvantages? In case there is a recurrence, this recurrence can happen in the grafted bone, resulting in loss of graft or the hardware, that is the plates, due to infection. So the immediate reconstruction cannot be practiced in tumors where there is a possibility for recurrence. You need to wait for a while, observe the patient periodically, see if there is recurrence or not, and if there is no recurrence, then you go for a reconstruction, and that is called as the late reconstruction or delayed reconstruction. So when you come for delayed reconstruction, you need to have at least a 6 months waiting period for where you will be observing the patient for recurrence. And muscular deformation and displacement of segments should be avoided. So normally what we do is we keep a defect bridging plate which will maintain the position of the mandible, or at the same time maintain the muscle balance too. Later, when there is no recurrence, you can go in for a grafting procedure where complete reconstruction is achieved. So maintain the residual mandibular fragments in normal anatomic relation with either intermaxillary fixation or a reconstruction plate. So those are the reconstruction plates, the defect bridging plates which are used for reconstruction purposes. For the segmental resection done in the body of the mandible, you can use the plate which is given in the first picture. And if your hemimandibulectomy is done, the second picture where you see a reconstruction plate in the shape of an L, which mimics the anatomical shape of the mandible, it can be used. So there you can see a hemimandibulectomy without disarticulation has been done, and a reconstruction plate is used where you can see 4 screws which is fixing the mandible to the, fixing the plate to the symphysis area or the parasymphysis area of the mandible, and the other half the plate is fixed to the remnant of the ramus which has the condyle and the coronoid process. You can see that's how a recon plate is fixed. So here you can see a graft, the radiolucent bridge you see there, okay, where the plates are also seen. That is the graft, and the graft is fixed to the remnants of the ramus as well as to the parasymphysis region of the mandible. So there is a graft, and also using the graft implants have been placed. So this is a picture where a resection has been done for a tumor, and reconstruction also has been done along with the implants, which has helped in the rehabilitation. It's another picture. That's a fibula graft. The fibula graft has been harvested, and that has been used for reconstruction of the defect. There is a obturator or palatal plate which is used for covering up the defect in the maxilla after a maxillectomy. So when you talk about odontogenic tumors, ameloblastoma is considered to be the most common odontogenic tumor, and by definition, ameloblastoma is a true neoplasm of odontogenic epithelial origin, and it does not undergo differentiation to the point of enamel formation. So according to Robinson, ameloblastoma is a tumor that is usually unicentric, non-functional, intermittent in growth, anatomically benign and clinically persistent. So, what are the clinical features of ameloblastoma? The average age where it is infected, where the patient is infected with ameloblastoma is 33 to 39 years. There is no significant sex or race predilection. The site of occurrence is usually the mandible, which can be seen in the molar region, angle or the ramus area. It can also be seen in the maxilla, where can be seen in the anterior maxilla, molar region, maxillary sinus or the nasal cavity. Usually it is slow growing and asymptomatic. The most common presentation is swelling and facial asymmetry. It's having a very slow growth with reactive bone formation, gross enlargement and distortion. In later stages, there will be thinning of bone. So that is a cortical plate will get thinned up, and on palpation you will elicit the characteristic eggshell crackling sound, and if untreated it can perforate the bone, spread to the soft tissues, and then the excision can be difficult. The average size is 4.3 centimeter, and pain is not a usual symptom, and other symptoms are displacement of mobility and resorption of the teeth. There will be paresthesia in the region affected by the ameloblastoma. Occlusal alterations can be seen. Failure of eruption is also observed. Radiographically, it is a multilocular cyst-like radiolucent area with well-defined margins. It is called as honeycomb pattern or soap bubble appearance. You can see it's multilocular, several locules are present, and with the intercepting radio opaque plates, so that gives the honeycomb pattern or the soap bubble appearance. And few radiolucent areas with small daughter cysts can also be seen, and the bony margins are typically scalloped. May be associated with an impacted tooth. Okay, and the roots of the adjacent teeth might undergo resorption or displacement, and may perforate the overlying bone, but the periosteum is rarely perforated. So those are the radiographic and CT pictures of ameloblastoma. You can see the honeycomb or the soap bubble appearance, and the CT you can observe the expansion of the cortical plate, and one area you can see a thinning of the bone, means the bone is perforated. So what are the histopathological features? As you all know, it has a follicular and plexiform type, and the subtypes are acanthomatous, basal cell, granular cell, desmoplastic, mural, peripheral, and malignant subtypes. So what are the treatment? Basically, it's a conservative approach. You can either go in for curettage or cryosurgery, and if the tumor is very extensive, then you go in for a more aggressive surgery. You can go in for a marginal mandibulectomy, also known as en bloc resection, or segmental resection without continuity defect, or you can go for a segmental resection where the inferior border of the mandible will also be excised out. So that is resection with continuity defect. And if it is a very huge tumor involving the ramus as well as the angle of the mandible, then you have to go in for a hemimandibulectomy, which can be either with disarticulation or without disarticulation. So that brings us to the end of this lecture. If you have any doubts and questions, kindly post it to the portal. I'll be able to answer them. Thank you.